Hello everyone, and thank you for the invite to talk at the 2025 Macular Society Annual Conference. My name is Dr Rachel Hanson and I work as a Research Fellow in Ophthalmology at York and Scarborough Teaching Hospital. And during my talk today, I'm going to present some of my research, which investigates the relationship between the vision and the brain. So to begin, the visual pathway, it's made up of two sections, and the image on the screen here is of a head looking towards a butterfly. And what we see in our visual world, in this case the butterfly, is first detected with our eyes, and this part of the pathway is referred to as the anterior visual pathway. And that information is then sent to the visual cortex in the brain, which is responsible for processing visual information. And this part of the pathway is referred to as the posterior visual pathway. And the work I'm going to show you today investigates the relationship between these two parts of the pathway when there is particular damage to the anterior visual pathway, particularly to vision loss associated with age-related macular degeneration. Now, all of you may be very familiar with the many different types of technologies that are used to measure the anterior visual pathway, or what we can see with our eyes. And these are often used in clinical settings, such as hospitals, and they're becoming more common in community settings, such as your local optometrist. And these technologies include measures of visual acuity, so for example, reading the letters on a letter chart, such as that shown in the top left of the screen. And we also can use different technologies to image the eye or take photographs of the surface of the eye, such as that one, the image shown on the top right, so we get a lovely colour photograph of the back of the eye. And we also get to measure the thicknesses on the different layers of the eye, for example, like that shown at the bottom right of the screen. And these types of images can be used can be taken rather, from a type of machine called an OCT machine, or optical coherence tomography machine. And in addition to these clinical measures of the eye, in my research, I also use technologies such as magnetic resonance imaging, or MRI, and this is to measure the structure and the function of the posterior visual pathway, or the brain. And the image on the top left of the screen is one of the MRI machines I actually used in my research. And the image shown here on the bottom right of the screen is actually my own MRI scan. And here you can see it's a cross-sectional slice through my head, and you can see my nose and my mouth towards the right of the image, and the back of my head on the left of the image. And I specifically use MRI to investigate how the posterior visual pathway in the brain processes what the eyes see, and what changes may occur to the function and the structure of the brain, in particularly in those individuals who have vision loss associated with age-related macular degeneration. And the part of the brain dedicated to processing this information, visual information that is located at the very back of the brain, which is highlighted by the red circle on the image in the bottom right. And for those unable to see the image, if you just place your hand on the back of your head, just where your head starts to dip into the back of the neck, and that's where the visual cortex is roughly located. Now, during an MRI session, I often run a specific scan which measures the function of the brain. So whilst an individual is lying in the scanner, I can present stimuli such as a black and white checkered expanding ring. And those examples are shown in the two images on the top right of the screen. So these checkered rings start as a central circle, which is black and white check, as I say, and then that expands over time, expands outwards, to then look a bit like a donut. So you've got an outer ring of a black and white checkerboard and nothing in the centre. And I can measure which parts of the brain become responsive, or they react when this type of stimuli is shown to the eyes. So what we then do is we can map this kind of activity or the function of the brain kind of in a coloured render, so that we can see how or what parts of the brain process to what types of stimuli presented in our visual field. So you can kind of think of this like the coloured arches of a rainbow. So the small inner arch will activate the central visual field, and the outer arches of the rainbow will activate the peripheral visual field. So we can colour match these rings, or what part of the brain will become active, to the central visual field and the peripheral visual field. And this activation can then be mapped onto the brain, which is what I'm showing in the larger image at the bottom of the screen. So you can see that in the coloured circle towards the left-hand side of the image, we have these coloured rings, and the central visual field is shown in pink, and the peripheral visual field is shown in blue. And when we map that activity onto the brain, you can see that it's actually quite a large area of the brain, right at the very back of the brain, that processes that central visual field information, and that's shown in pink. And the peripheral visual field, shown in blue, activates more posterior parts of the brain, so further along the brain. And what I do is I can compare this brain function in people with and without vision loss. So the example here is of an individual that would not have any visual loss. So they can clearly see the picture on the bottom left of the Mona Lisa. We can show stimuli within the scanner that they can clearly see, and when we map that activity onto the brain, we get a lovely coloured map. So we get that pink activity at the back of the brain, and then the bluer activity for the peripheral visual field, more posterior in the brain. However, when we then do that same scan with somebody with central vision loss due to age-related macular degeneration, those individuals have difficulty seeing the image of the Mona Lisa. So there's a black circle within the central visual field. And that's also represented by the black circle within the upper coloured rings, and again, in terms of the activity on the brain. So because the eyes are no longer able to detect that information from the central visual field, no information gets sent through to the back of the brain. So when we map the function, that it's silent. The part of the brain that would usually process central visual field information doesn't respond to that information because the eyes cannot detect it. So we don't map any activity there. However, in the more peripheral visual fields, the activity returns to a normal coloured map. So I also said at the start that I can use MRI to measure the brain function and brain structure. So this is an example of what I mean by brain structure. So we use a different type of scan, which allows me to measure changes in thickness of the actual brain tissue. So for here, I'm showing an example. Again, it's just a snippet from the back of the brain, which is the area we're focusing on. And there's, in the top left image, you can see that there are two boundaries, a purple and a green boundary, and a yellow arrow line between the two. And we can just measure if that thickness between those two boundaries changes in particularly the part of the brain that would process the information from the central visual field, which is currently damaged or no longer receives the input from the eyes. So I measure changes in thickness, particularly in the part of the brain which would normally process central visual field information, which is most affected in AMD. And I also then do the same kind of measurement in another part of the brain, which processes information from the peripheral visual field, which typically isn't affected in AMD. So you may be asking yourself at this point, why is all of this important? Well, in my research and that of the wider team, we've shown that in those areas that no longer receive input from the eyes due to AMD, those areas show changes in both function in terms of reduced brain activity. So you can see that in the central images here. So the top row is of an example of an individual who does not have vision loss, and the bottom row of images is an example of somebody that does have central visual field loss. So you can see the difference in terms of their vision. The bottom row is blurred in terms of the vision chart. The central images is an example showing that there's reduced brain function in terms of the activity that we can map onto the brain. And then the last two images are examples in changes in structure. So we can see that in those parts of the brain that no longer receive input from the eyes, they actually reduce in thickness. And the important thing here is, despite finding these changes, they don't occur immediately upon diagnosis of AMD. They occur gradually over time as AMD progresses. So what does this mean if I have AMD, or if you have AMD? Well, I don't want the talk to be all doom and gloom. So the fact that the changes in both function and structure of the brain do not occur immediately, but they occur over time, means there's a potential window of opportunity for vision restoration and to prevent permanent brain changes. So you can consider the brain as a muscle which has the potential to bounce back should input from the eyes be restored. So there's also the possibility of prolonging the changes in thickness with different types of neuroprotection measures if administered within this particular window. Now, a slight change in focus from the work I've been showing so far. Charles-Bonnet syndrome is often experienced by individuals with vision loss, including from AMD. And whilst I don't look at Charles-Bonnet syndrome directly myself, I wanted to briefly discuss how Charles-Bonnet syndrome may be linked to changes in the brain in those with vision loss, which I have touched on already in my own work. And there was this study here that was published back in 2022, and it's by researchers who used MRI and used similar techniques to what I've already shown with my work. And they used MRI on 3 groups of individuals. The first group of individuals had central vision loss, predominantly due to AMD, and they did experience Charles-Bonnet syndrome. There was a second group of individuals with vision loss due to AMD who did not experience Charles-Bonnet syndrome, and there was a third control group of individuals who didn't have vision loss, so they didn't experience Charles-Bonnet syndrome. And using similar scans that I've previously talked about, these researchers showed changes in the posterior visual pathway in those with vision loss compared to those without vision loss. And that's indicated by the areas in the brain images on the bottom right of the screen that are highlighted orange. So this is similar to what I've already shown in my work. And this was irrespective of whether those individuals with vision loss experienced Charles-Bonnet syndrome or not. However, they didn't show any structural differences between the individuals with vision loss who did experience hallucinations and those that did not experience hallucinations. So the researchers suggest that the structural changes to the brain may actually predispose to visual hallucinations associated with Charles-Bonnet syndrome. And the primary mechanism is likely to be due to the alterations in connectivity between different brain regions. And obviously, as the areas in the visual system adapt to the reduced input from the eyes. So the take-home message on the talk that I've given today, just to wrap up, whilst I've shown evidence that long-term reduced visual input due to age-related macular degeneration does cause significant shrinkage in the areas of the brain responsible for processing the lost vision. Importantly, there is a window of opportunity for the brain to bounce back and return to processing vision should input from the eyes be restored. And this is one of the many areas of research that we are currently investigating within my research group. So just to end the talk, I just want to thank my close work team, so Professor Richard Gale and Mrs. Archana Erodi, who I work with at York and Scarborough Teaching Hospital, and colleagues from the University of York, where I completed my PhD, so particularly my supervisors Heidi Basler and Tony Morland. And lastly, a big thank you to anybody who may be in the audience who took part in any of my research, and to the whole participant group. So thank you very much.